Thank you so much for the introduction. And for some of you, you may recall that yesterday Tom did a very good job at presenting on the 1990s. And I think for me as UNAIDS, it's humbling to see how 1990 has taken up. And even our colleagues from the industry use that for the presentation in the afternoon. So there's that level of engagement and contagion, a positive one, I would say, regarding these targets. Very recently, I even saw how our colleagues from the tuberculosis arena are also taking on the 1990s and looking at the cascade on how to achieve what we're proposing. So we're going to look at, I want to try to present complementing information and also reiterate a bit of what Tom said yesterday. And certainly treatment as prevention, let me start there. We've highlighted as a game changer, and we've heard from several of you on how this is moving forward in the world from your different studies. From the perspective of public health and coming from the UN, I cannot avoid the mention of the Sustainable Development Goals. I think that during the opening on Sunday, I alluded to them, and I alluded to the Millennium Development Goals and how the world basically presented the report card in 2015, and we realized how HIV, which was one of the objectives, remains part of the unconcluded agenda. So we need to make sure that under objective number 3, which is health, in this new set of goals, we see more progress happening. And we talked about innovation. We've heard about innovation through the whole day yesterday, and I'm going to try to include some elements. And, you know, the fine print or the agreements that governments endorse and that become a part of the advocacy tools for civil society when bringing or reminding the decision makers about these promises and how they need to be, you know, delivered. And fast track is what you know, contains the 1990. And fast track, why? Because really we have very little and short time. The 1990 is for 2020, and we are already at the gates of 2018. So, and the new infections among adults, that's the target for hopefully getting there, and zero discrimination. The 2030 targets are much higher. And as you can see, 1990 is just one of the 10 commitments that the governments made in the political declaration. There is the elimination of HIV infections among children by 2020. And the Caribbean in particular is doing a very good job about it. I think we mentioned Cuba, but I know about countries very close to where we are now that will be certified very soon. And I applaud that, and I encourage as frequently as I can the decision makers in the Caribbean to move forward in that direction. This region has all the elements to become the first region in the world to eliminate mother-to-child transmission. Other areas that have to do with combination prevention, of course, gender inequalities, engagement of youth. I alluded to this the other day in the opening. We need the new generations to become engaged. The new scientists, the new advocates, even the young people living with HIV. Now they're more visible. It's easier. Even though there's still stigma and discrimination, it's easier to come out and say, I live with HIV, particularly in countries where ARVs are available. Again, social protection, service delivery led by the community, and certainly the issue on legislation. Now, if none of that happened, if we went about business as usual by 2030, this is what we would have, 2.5 million new infections in 2030. if we continue doing business as usual. If we fast track, this is what we have. So it's an interesting difference, don't you think? And now from here to here, it's all the work that we're all doing that will make it happen. Now, to make sure that we target our efforts, UNAIDS and co-sponsoring agencies, 11 of them, decided on a number of countries, 35 of them, where we think we need to highlight our efforts. These 35 countries comprise 90% of all the infections in the world. So if we are to focus our attention in them, we should definitely start doing a good job. In this part of the world, Latin America and the Caribbean, we have Brazil, and evidently Brazil reports about 800,000 people in with HIV at the moment, out of the 1.2 million people in with HIV. But then Jamaica and Haiti are the two countries in the Caribbean that have been labeled as priority fast-track countries. And we engage with them as frequently as possible, and partners also engage with them as frequently as possible in terms of moving the response forward. Global Fund has dedicated grants for both countries, and now only speaking about the Caribbean. And we just heard a presentation about Haiti and how they're moving forward, and they should move forward. The core fast-track principles are those: ambition. It's, yes, we can do it. I remember in 2011, when we had our previous political declaration, there were 6 million people on treatment at the time. And I remember when Michel Sidibe said there should be 15 million people on treatment by 2015. And there were so many voices that said, impossible. From 2011 to 2015, go up from 6 million to 15 million, impossible. We had not even gotten to the end of 2015 when there were already, that target had been achieved. And as per the report that we launched this past July, 19.5 million are on treatment. And our next challenge, our next ambitious challenge, is to have 30 million people on treatment by 2020. So it's important to set targets, and even if we miss them, we know that we missed them by how much. But all countries, I believe that beyond the 35 priority fast-track country list, I tell countries all of them are fast-track. Focus. We cannot be working in the entirety of a country. We need to find out through the tools that some of you have presented, where is it that the epidemic, we used to do our epidemiological reports looking at the number of new cases and so on. And the question is to the AIDS program directors or managers, where will your next 1,000 new infections will take place? And let's go out there and find them. Change. We invite people to change, and everybody is up for change. Yeah, let's change. But do you want to change? And that's when it becomes difficult. Well, you know, I'm used to doing things my way in the lab, or I'm used to doing things my way in government and so on. But we need to have an open mind about the paradigm shift. Speed is of the essence. Saturation also is of the essence. We've heard yesterday about the importance of linking to treatment. So many missed opportunities. We're so happy. We detected so many new people in with HIV, but then when you look at how many of them were linked to treatment, we see how much we're failing there. And we're failing the individual. Like, of course, not to mention just the program itself, but that should not happen. And human rights. UNAIDS pushes for a human-centered, people-centered approach. And we always need to think about the people. And people living with HIV, people affected by HIV, and at all ages, children, youth, and all them, young adults, and even older than 60 or 70, who are also getting infected, according to the reports. So here is, after that introduction on fast tracking, let's do a review of the 1990s progress that was started here yesterday. These are the targets globally, and I think that the world is sort of on the road, as Tom was saying yesterday, 70, 77, 82. And the idea here is us, let me see, here's the pointer here. All right. People living with HIV that know their status, and this is based on the 100% here, and each of these will give the denominator basis for the next. Sometimes countries prefer to see it in a different way, and we need to agree certainly on being able to compare how these numbers are set up. Oops. Okay. This is where the world is, as I was saying. These are the figures for the Caribbean and for Latin America. Latin America is doing a bit better in terms of testing and linking to treatment. And the Caribbean will need to improve, particularly here. We need to see more testing done. Yesterday, you may have heard that Cuba was one of the countries that was reporting a number of new infections. We looked at that, and we're going to see a chart further down the presentation that shows how the Cubans have increased the testing and enhanced the number of people that they've been able to identify as living with HIV. 1 of 3 people living with HIV in the Caribbean is not diagnosed yet, so this is something that we need to work on. 4 of 5 diagnosed people in the Caribbean are on treatment. That part we're seeing that it's happening well. And 1 of 3 on treatment in the Caribbean are not virally suppressed. Same numbers that I showed before with a different way of presenting. Yes, this is a busy one, and I encourage you to download the report from the webpage. You'll be able, if you have an iPad, you can download it there. It's very user-friendly. You can play with expanding the sizes of it. But look at the numbers here, and look, for instance, on the first 90. Where do we have some green lights, or where do we have the red numbers? Let me see Cuba. I was talking about Cuba. Look at Cuba here. It's a high proportion of in the first 90 people who have been identified as living with HIV, and then people on treatment, and then people who are virally suppressed. They're doing about, I think it's one of the countries that is doing a good job in keeping the 390s there. We have Haiti here, who we heard the report. Not here, I think it's a 41. I'm even myself so close here cannot realize clearly. 61. A good portion of them are put on treatment, but we need to see an increase in viral suppression. I brought information for Latin America as well in order to compare. 4 of 5 people living with HIV in Latin America are diagnosed, so the numbers are a bit higher. 3 out of 4 diagnosed people in Latin America are accessing treatment, and this is important. But let me stop here for a while. Stockouts. That's a very difficult situation at the moment in several countries in Latin America. And it's not because there's no resources, financial resources, I mean, but forecasting is something that needs to be improved. Procurement is something that needs to be improved. And I was talking to Valerie Wilson the other day about a mechanism that OECS countries are starting to think about on joint procurement. And that's something that we need to think, how we solve the stockouts to make sure we are able to address this. So, again, the elephant in the room for me in Latin America right now is Venezuela. There are 5 countries in Latin America that drive about 90% of the new infections, or even the people in with HIV, and those are, by population size, Brazil, Mexico, Venezuela, Colombia, and Argentina. And in the case of Venezuela, we estimate about 120,000 people in with HIV, and they had reported about 75,000 people on treatment. But they have been out of ARVs intermittently for the past year. and what is it doing to the people? Again, to my people-centered approach. I can give you the 1990 talk and the narrative and the guidelines and so on, but what's happening with the people? When the shipment arrives, it makes it to customs, spends 15 days there just because, and then going to central warehouse and distribution takes a long time also to get there. Believe us, from the UN agencies that are involved with this, we're trying to make this happen faster, but we also need the global solidarity beyond resources to also be present there. 4 or 5 people in treatment are virally suppressed. And again, here are the figures I was talking to you about. I can tell you that the numbers here are good. The 3 numbers, the 3 sets of numbers are good. And the idea to put all of these specific numbers by country, it's so that you can tease out. Yes, the region as a whole may be doing well, but we have the Bolivias, we have the Honduras, we have the, for instance, let me see, which the other one, Paraguay, and the region that may do better. This is a graph we put together that aims at looking at the country's epidemics and bear with me in the axis. This is Latin American countries only. And here is the coverage of ARVs at the bottom. And on the left side, you have GNI, gross national income per capita. If I was to determine the average coverage, that now we have a split of countries. And now if we are to set also the average GNI in the region, we end up with this 4 quadrants, where towards the right we will see greater coverage of ARVs, and going up we will see larger or more income. Well, it's not a surprise to see Chile, Panama, Costa Rica, Brazil, Argentina here. And we started to see, these are numbers for 2014, probably reporting 2013, that Venezuela had started already going down in terms of its coverage. But it's interesting to point out to El Salvador, because even with not such a large wealth in terms of GNI, they had a very important coverage. And the size of each circle represents the contribution from domestic resources, okay? The larger the circle, the more the country pays from its own pocket. The smaller it is, the larger international cooperation. So, this is the Caribbean. And again, this is with the data that we have. I need to continue working on this chart. But, well, obviously Barbados is here. Higher wealth and higher coverage. And Cuba is here also, as expected. Haiti is here. The size of the circle represents the high dependency on international resources, as we were explained earlier. That doesn't mean that we don't have a strong response or we don't have an excellent job, that, as we just heard. But moving towards sustainability will take a lot longer if we just take into consideration this slide. Progress towards coming back to 1990 and implementing the WHO Treat All guidelines. This is the map that we presented for Latin America, and this is the map that we presented for the Caribbean. And this color that's supposed to be yellow, I think it's more like mustard or green, it's CD4 count of 350. This is the threshold they're using for treatment. They haven't yet adopted the most recent WHO guidelines. These reports sometimes give us a bit of a headache because evidently civil society has gotten the report and told the government of Chile, you guys are not doing your job. Look at all the new infections that we're getting. We're still basically not adopting the guidelines of WHO. And this is a high-income country. I heard yesterday that perhaps Canada and the US may not be necessarily also covering all of their citizens yet. And I'm sure that we will hear some more about it in the next presentation. But this is our job, to point to accountability. We signed the political declaration, we endorse the Sustainable Development Goals, but at the same time, we need to meet and be accountable for those agreements. How do we take a stock of what's going on? Basically, every 31st of March, all countries have to come to us and turn their reports. And then we tally them and we do some modeling and particularly on estimating new infections and so on, what you see in the report. And this is where most of this is coming from. Look at the number of new infections, both in Latin America and the Caribbean. Look at the reduction of new infections, matching the map that I was showing before. Look at El Salvador, local investment, high coverage, reduction of new infections. And same thing I can say here about these 4 countries here in the Caribbean. But why persistent late diagnosis and death despite treatment availability? And this gives me the chance to transition to the next part of my presentation, that as I was asked by CCAS. People aren't dying for lack of medicines necessarily in this part of the world. Stigma reduces testing uptake in the Caribbean. And these are the most common responses that we found from 8 Caribbean countries about which factors discourage people from getting tested. Concerns about stigma, if news of a positive result gets out, people are afraid. Some people would say, well, this is a small city, and everybody will find out about my status. Confidentiality concerns, of course, linked to the first, and uncertainty about how to handle a positive result. These polls, again, were conducted between 2013 and 2016, and we shared these with authorities, and we're still hoping to see more actions and policy develop stemming from these. Despite progress, again, it's still challenging living with HIV for many. Look at this figure. 38% in Belize have changed their place of residence because of their HIV status. That's a good high proportion of people. 8% of people living with HIV in the DR said that they had been denied health service, including dental care. We can talk about beautiful programs that are being implemented in all of these countries, but we still, in the health professionals, you may recall that in March this year, we had the Non-Discrimination Day around the world, and this year's theme was on non-discrimination in the health care settings. We need to do a lot more of that. 11% in Jamaica reported frequently experiencing verbal harassment. I could say the same thing about Latin American countries. 19% of women living with HIV in Panama were told to be sterilized. 17% in Latin America have also been harassed or threatened, and 27% in Colombia say they were denied health services because of their health status. These are numbers from 2012, 2014, and we need to do better than that. It's not just collecting this information, it's really how do we turn these results into policy changes and meeting not only with ministers of health, because this takes us further. We need to have a wider audience in terms of policy changes. Here I have a couple of voices that I would like to join me during these presentations. I need you to hear from the two affected individuals. Just for clarity, we have permission to broadcast this.
When it comes to you now, they're dealing with you in a different way. So it's hurtful. It was hurtful to me. But there are some who you will meet and they will uplift you and they will give you the encouragement and they will try and talk to you and get encouragement to do the right thing. Ask you if you're taking your meds, make sure you take your iron, your vitamins, and they will encourage you to do the right thing. But then again, some of them is very hurtful. They mightn't tell you hurtful things, but the way how they might deal with you when they come to examine you, because during that time they have to examine you, see if the baby turn or whatever, how far the head is. They'll put on like 2 gloves, 3 gloves, because they're afraid to get infected from this. But like they don't know the way how the disease is transferred then. Because they are health professionals, they're supposed to know how it is transmitted from one person to another.
This is a woman from Trinidad, and I think we have another one. Overall, criminalization of sexual and gender minorities, sex work and drug use contributes to stigma and discrimination and violence against key populations, including by state.
I remember when I went and I handed them the letter and they attached this letter to your file, so they gave you a date to come back to join, to start clinic. And, when I went back to join, I was kind of like dreaded when they would call my name. The thing is about that is that where you are sitting is not very far from the other person that might hear or that kind of thing. And the nurse was talking kind of loudly, kind of way, do you know the risks that you're taking and, this kind of thing. And you could see she had a kind of attitude about it. So it was really frightening. It was really, really, really frightening for me. But I remember wanting my baby to be healthy at all costs. And then when I was pregnant with my son, I didn't get to see a doctor. If I see a doctor twice in that pregnancy, well, excepting for those at MRF, I saw a doctor plenty times. And I didn't request to see a doctor because, I knew that other people got to see doctors and stuff. But I didn't request to see them because I thought, well, maybe it wasn't maybe as a woman living with HIV, I don't have that.
Thank you. Evidently, many of you have done qualitative research and have heard probably some of these similar responses, but it's certainly a reminder that we need to have these people-centered approach and think about how we can improve even in our own settings if we are researchers, how our staff in countries in this part of the world can also be better trained or do some awareness raising. We talk about this with ministers all the time. Now, with the support of Pan-Caribbean Partnership Against HIV/AIDS, PANCAP, and the Health Policy Project and University of the West Indies, we're measuring stigma levels among medical and non-medical healthcare workers, supporting the development of interventions and monitors progress. The project was piloted in 2 Eastern Caribbean countries, Dominica and St. Kitts and Nevis, and it has since been repeated in Antigua and Barbuda and Barbados. And the survey looked at the attitudes of both medical and non-medical staff. And you can see, some of the expressions. It is appropriate to sterilize a woman. Observed a co-worker unwilling to care for a patient with HIV, or people get infected with HIV because they engage in irresponsible behavior. We do not leave our cultural background outside of our clinics or our labs, and this is something that we need to address. Following the study in St. Kitts and Nevis, they went on to develop a stigma reduction training that included workers at all levels. And most of them, about 89% of the country's health facility staff, participated over a year-long period. And this is what we would like to see happening around many of the facilities in this part of the world. This is the code of conduct and so on. So following up on the findings. Key Caribbean laws and policies that undermine treatment. 5 countries have HIV-specific restrictions of entry, stay, or residence. And some countries, when you raise these, they come back to you and say, oh, but we're not enforcing them. But they are in the books. They are still the law of the land. 5 countries have laws that criminalize HIV transmission. 10 countries criminalize same-sex intimacy. 12 countries, aspects of sex work are deemed illegal. And in 1 country, Guyana, cross-dressing is illegal. And we just heard a while ago the issue in Haiti where it is not, HIV is not criminalized, but now the issue is with same-sex marriage. And we're going to start to see that more and more as civil society and the communities are looking for, accessing the rights that they are entitled to. Change is possible. Belize in 2016, last year, Supreme Court ruled that Section 53 of the Criminal Code, which criminalized sex between men, among other sexual acts, was unconstitutional. And perhaps I can hear later from citizens of the Caribbean outside Belize how they felt about that, because this was seen as an advancing moment in terms of decriminalizing and helping move the response to HIV. In Trinidad, Parliament outlawed child marriage, removing various marriage acts that allowed girls to marry from as young as 12 to 14. So there are several areas, and I feel when I talk to activists or civil society working on HIV, that at this stage in the epidemic, it's greater than 30, 35 years of epidemic, we cannot work by ourselves. We need to, make linkages, if we have not yet, with other social movements. And sexual and reproductive health and rights are out there, and certainly poverty. We see a commonality of the activism being targeted in the extremes, violence against activists for climate change, activists for sexual and reproductive health, activists for HIV prevention. And that's happening in this part of the world. And the worst of it has been killing or dying of it. Every time I hear it, I think there's a fire going on. So this time it's because I'm fired up. So Political Declaration 2020 targets, it's basically as part of a 2016 political declaration on ending AIDS, countries have committed to review and reform laws that reinforce stigma and discrimination and restrict access to services, travel restrictions, mandatory testing, punitive laws, and so on and so forth. Yet, we have some states that are updating their former HIV legislation for the best, and others that actually, making it a bit more difficult to bring a strengthened response. As I was saying on Sunday, we feel so happy to have turned the corner and say now more people receive therapy than not. It's taking us a long time, and but we cannot dismay. Latin American and Caribbean serious discrimination targets. I feel that this was addressed very briefly yesterday. Latin American and Caribbean countries have met. In 2014, we met in Mexico. In 2015, we met in Rio de Janeiro. And in November, first week, we're meeting in Haiti. And in the first one, we agreed on treatment targets, regional treatment targets. In the second one, we agreed on regional prevention targets and non-discrimination targets. And this time around, we're going to talk about sustainability. What's going to happen after the Global Fund and PEPFAR and all of these aids leave, and how the response will be able to be sustained. As you can see, starting from 1990 is a good conversation point. I think framing it under the fast track approach that UNAIDS has proposed, it gives us a wider environment. Treatment is good, I love it. It's doing a lot of good in terms of prevention, but it's not enough. We still need to address, particularly if we are having a people-centered approach, the human rights, the non-discrimination areas, to the best of our abilities. I thank you for your attention.
Now César is ready for questions. So my name is Clement George, and right now I am from the University of the West Indies. I just joined, so I really don't know the situation as it is in Barbados. But one of the issues that you talked about is the issue of laws and policies right here in the Caribbean. Not only is individuals who are HIV positive barred from entering certain areas, but individuals who are in certain countries are not given access to medication because they lack legal standing. And when Dr. Joseph talked about, for example, Haiti, there are many people, Haitians, who move to different countries, and because they do not have status, they do not get tested, they do not get treated, they go underground, but yet they do have sexual lives. And that is, and I'm not even sure if they're counted in part of that 90% that we need to reach, because they're not represented. And I'm just wondering, what can we do to, support or probably support governments to embrace and engage everyone, no matter what status they have in the Caribbean. Yeah.
No, thank you so much for your question. And I think that I would translate your words into what has been in the motto of the Sustainable Development Goals, which is no one left behind. And I am reminded about no one left behind by so many groups every time. The indigenous communities come to me and you say, well, where are we? Without the indigenous people, we're not going to reach the 1990. Or without the migrant populations, we're never going to reach the 1990. And you are very, very right. I feel that by engaging as many groups of civil society, because in this people-centered approach, we at UNAIDS give a very important role to civil society. Yes, decision makers, they need to do their thing, but the civil society needs to be there and stand out and demand accountability. We try to be as thorough as possible, and when we provide support or to strengthen the response in any given country, we raise, that we need to think about these communities. Certainly, at the same time, the focus is important. Go after the low-hanging fruit and make sure that we get as many positives as possible on treatment.
Hi, Dr. Núñez. I have a little concern, and I hope you can help me.
Well, I hope.
I hope so. Yeah. You mentioned about the priority countries for fast tracking. You mentioned Jamaica. You mentioned Haiti. Yeah. And in another breath, you mentioned that you state all countries should fast track,
Yes,
which sounds excellent. But are all countries getting the resources to assist them in fast tracking? Take, for instance, Barbados. Barbados have always been penalized for the quote-unquote high development index and all of our indicators, HIV, etc. But we did have very good governance, especially through Prime Minister Arthur with the World Bank loan, etc., etc. So we were able to put a lot of things in place and set an example throughout the region. Now we have no loan, we have no money, but we still have the status, basically. Yeah, and really and truly, I feel as though, as we do better, rather than being rewarded, we're being penalized for doing good. And, you begin to wonder. We just had Carifesta, and it is one Caribbean. We had droves of people from Haiti, from Jamaica, and we're purporting one Caribbean. Yet you're singling out individual countries for aid within this one Caribbean. If we want to get the 90-90-90, we really have to look at the one Caribbean and see how we can help that one Caribbean rather than thinking that some countries don't need help. You showed the wide zones, of development, and therefore they need less help than the ones with the smaller zones. But really and truly, we're not going to reach that 90-90 if we don't address a one Caribbean. All right, so I hope that you can help with this aspect, because I always feel, even when I was at the United Nations, that, we're penalizing the good work of the few countries that really coming together and pushing to do good work, rather than, seeing how we can help the entire Caribbean to move everybody forward to that 90-90-90.
No, thank you so much. Thank you so much. Your point is well taken, and as a matter of fact, it's a reflection that I usually get in some of my visits. And the thing here is that this response needs to be multi-sectoral. And in terms of the Caribbean, I see the regionality as an asset. How the countries come together, and I hope that Derek is going to address some of that when he takes the floor. But there's been a lot of leadership in this part of the world, in the Caribbean, from many years ago, and the Pan-Caribbean Partnership is one of those examples, and how the Global Fund, for instance, provided a grant to PANCAP and another grant to CDC so that they could work together in mobilizing a wider Caribbean response beyond the priority countries analysis. Something we said from the beginning of the epidemic, I recall, HIV, it's not only about health, it's about development. And one of my first slides today was about the sustainable development objectives. And this means that this dialogue should not be only within the ministries of health. We need the ministries of social protection, we need the ministries of education, and more importantly, we need the ministers of finance. I tell the ministers of finance many times, you have your minister of health knocking on your door every year before budget time, because there were, 1,000 new infections last year, or 500 new people on treatment, and he needs to pay for those drugs. And you have to find a way within the fiscal space, short fiscal space, because now agriculture wants a piece of that fiscal space, and highways, and labor, and everybody else. So I think that what we should do more about is prevention. It's good that we are thinking about linking to treatment all people who already live with HIV, but we need to do a lot more with prevention. The shorter the line of new infections is, the better for the finances and the development of the country. I know I have not responded in the entirety of your question, but it's my reflections.
Okay.
Dr. Springer.
Thank you very much, Cesar. And I really want to respond to the question that was asked, because I think that the question speaks to the issue of equity.
Yes.
UNAIDS did not decide that Haiti and Jamaica would be on the fast track. The fast track is for everyone. However, the donors made that decision in terms of the countries that they will prioritize. So for the case of Haiti, Haiti is deemed to be a country with challenging operating environment. That's how the Global Fund deems it. I sit on the Global Fund board. And so we ensure that when we were addressing countries with challenging operating environment, that Haiti was placed among them to ensure that funding continues for Haiti, given the burden, given the economic challenges that Haiti continues to face. In the case of Jamaica, you were with us in Panama 2 years ago when the Global Fund made it clear that they will transition Jamaica by the end of 2019. And as Director PANCAP, I said, no, we cannot do that. And so we advocated at the level of the Global Fund board, and I contacted PEPFAR immediately, and I said, I need you on board. We cannot transition Jamaica, given the tight fiscal space, and given the high prevalence, particularly among key population groups. Because when we talk about upper middle income countries, or we talk about high income countries, that is really on paper. It does not reflect the reality on the ground. And also, when we look at what is happening in the US right now in Texas, we know what could happen in the Caribbean, and it happens within a couple of hours.
Yes.
And as such, we made the case, and so we brought together Global Fund, PEPFAR, and others, and made the case that we needed to sustain that support for Jamaica, because they were threatening to transition them. At the recent PEPFAR Regional Operational Planning meeting, which was held at the US State Department in March, the decision was taken that they could not justify supporting these upper middle income countries in the Caribbean. And the only way to be able to support the Eastern and Southern Caribbean was to ensure that most of the support went to Jamaica, given the high prevalence, particularly among key population groups, and the fact that they did not have as many people on treatment. So it is that argument that was used to retain funding in the Eastern and Southern Caribbean. And so a decision was taken that 65% had to be taken to Jamaica in financial year 2018 and 76% in financial year 2018. What I think is important is that we have got to continue to engage our national governments for them to understand their responsibility. Because when we talk about shared responsibility, it's not just about the governments, it's also about the private sector. But the government has to provide the leadership. PANCAP has been having these high-level engagements, and we are now engaging with ministers of finance to really make this case, recognizing that the people who make these decisions are not ministers of health, but ministers of finance and heads of government.
Sorry, we are out of time. We thank you for the comments. We're going to move to the next presenter. Quick answer, César?
No, I think that Derek covered it very, very well. Maybe I can take your question outside. No problem. I'm happy to do that. And this is just facing reality with the guidelines and protocols and so on and so forth. It is what it is out there, and the world has changed so much. What was reality a year ago, it's not today. We see rockets flying over Japan last night. What's going to happen today? It's really something like that. So I will not take more time. Thank you, Patrice, and I know that we have a very good presentation coming up, and I'm happy to discuss with anyone else on the 1990s or fast track. Thank you.
Thank you, César.